Welcome to the first presentation of the basic induction course for pediatric cardiology residents. In this presentation, we will discuss the basic cardiac examination. Although we will be focusing on the local cardiac examination, yet general examination must not be overlooked in any cardiac patient. In the general examination, please note the general appearance of the patient if he looks toxic or in poor general condition. Also note the body build of the patient if he is having failure to thrive or stunted growth. Please examine the extremities, ensure good perfusion, and check for the presence of clopping. Assess pulse and blood pressure, check for cyanosis and oral hygiene, and also remember that palpation of hepatomegaly and auscultation to the base of the chest are parts of the general examination. Local cardiac examination include first inspection combined with palpation in addition to the auscultation. Inspection and palpation are done for detection of cardiac enlargement. Also, we have to note if there are any scars of previous operations, and we have to check for the presence of thrills. First, note if the patient is having any left pericardial bulge, which denotes cardiomegaly early in childhood. Second, check for scars of previous cardiac operations, which may include a midline sternotomy or a lateral thoracotomy. Then we have to go for the pulsations, including the apical pulsations, epigastric pulsations, left parasternal pulsations, as well as pulmonary and aortic pulsations. First, to detect the apical pulsations, we have to ensure there is no dextrocardia, and then we localize the apex with the whole hand, and then by one finger, and then use the other hand to count the intercostal spaces so that you can describe the site of the apex. A normal apex lies in the left fourth to fifth intercostal space mid-clavicular line, usually localized to one intercostal space with no special character. Displacement of the apex indicates cardiac enlargement. Also, the extent of the apex in more than one intercostal space indicates right ventricular dilatation. And sometimes with cardiac lesions, the apex can be hyperdynamic with volume overload or a sustained apex with pressure afterload. And this is an example of a diffuse apex extending in more than one intercostal space, denoting right ventricular enlargement, and also a hyperdynamic apex localized to one intercostal space, denoting volume overload. Next, we have to palpate for other pulsations, including the epigastric pulsations in the subcostal area, and then the left parasternal pulsations or heave, and then pulsations in the pulmonary area or the aortic area. At these areas, we are feeling for pulsations as well as for the presence of thrills. Usually, no pulsations should be felt at these areas. Presence of epigastric pulsation can denote right ventricular enlargement. Presence of left parasternal pulsations or heave denote right ventricular enlargement. Also, presence of pulmonary or aortic pulsations indicate dilatation of the underlying vessel. At these areas, a palpable thrill can be felt, which will be over the maximum intensity of a turbulence of blood flow. For the cardiac auscultation, we have to start with the diaphragm at the apex, and then we auscultate the axilla. Also, we have to auscultate the apex using the bell of the stethoscope. And then we move to the lower left parasternal area, upper left parasternal area, pulmonary area, and the aortic area. At each of these areas, we have to comment on the heart sounds as well as the presence of murmurs. The heart sounds are made by the closing of the heart valves. We usually can hear the dub, lub, dub, lub, dub. The lub is the closure of the AV valves, the mitral and tricuspid, while the dub are the closure of the semilunar valves, the aortic and the pulmonary valves. A murmur is an abnormal musical sound that can be heard because of turbulence of blood flow. One example is the VSD murmur, which is a harsh pansystolic murmur heard maximally over the lower left parasternal border and usually radiates all over the pericardium. Another systolic murmur that can be heard is the mitral regurgitation murmur. Which is a soft pansystolic murmur heard maximally over the apex and radiates to the axilla. And then we can have a murmur of aortic stenosis, which is a harsh ejection systolic murmur maximally heard over the aortic area, the right second intercostal space, and usually radiates to the lower part of the neck. The PDA murmur is quite different, being a harsh machinery continuous murmur with systolic and diastolic components. And heard maximally over the left infraclavicular area. One of the diastolic murmurs that can be heard is the aortic regurgitation murmur. A soft decrescendo murmur maximally heard over the upper left parasternal border and best heard with the patient leaning forward. Aortic regurgitation murmur is usually a low intensity murmur, and the lesion can be better detected by the presence of peripheral signs of hyperdynamic circulation. The other diastolic murmur that can be heard is the mitral stenosis murmur, which is a mid-diastolic rumbling murmur best heard over the apex. And this slide presents the most important point of the basic cardiac examination.